We will continue where we stopped, and that is on hydrochloric acid functions. Hydrochloric acid secreted by parietal cells or xanthic cells has a lot of important functions in the stomach and throughout gastrointestinal tract. In the stomach, it causes activation of proteolytic enzymes or pepsinogens. Pepsinogens are secreted by chief cells of the stomach in active form, in the form of zymogens, which makes a lot of sense because secretion in active form prevents the gastric glands from autodigestion, from being digested by proteolytic enzymes secreted in the glands themselves. And so pepsinogens are released from the glands in inactive form, and they are activated only in the cavity, which already means above the protective layer of mucus and bicarbonate. So that it serves as protection. Hydrochloric acid creates acidic medium in the stomach, required for the proper work of proteolytic enzymes. Proteolytic enzymes in the stomach require acidic medium, while proteolytic enzymes in the duodenum, those coming from pancreas, they require alkaline medium. So you see how medium changes from the stomach towards the duodenum and jejunum. It is acidic in the stomach and alkaline in the duodenum and jejunum. Hydrochloric acid causes denaturation of proteins, which makes it easier later for the pepsinogen to break them down. Yes, please.
What do these numbers mean on 5, 6, and 5?
Oh, that is the level of pH. Towards 6, 5.5 to 6.5 is mainly in the stomach of neonates and children until the age of 1. That is the medium required for the activity of the proteolytic enzyme that breaks casein of milk. This enzyme is called renin, double N, not to mix it with renin coming from kidney. And this one is absent or inactive in the stomach of adults because we have high acidity. So for us, when it comes to milk digestion, it's just curding of milk by hydrochloric acid. We don't have enzyme that breaks casein. Yes, please, sir.
What releases the enzymes for the stomach?
What releases? They're secreted by chief cells.
Pepsinogens, that's it.
Yes. Yes, please.
So the acidity of the stomach changes, of course it changes due to secretions, right? HCO3, HCl. But does it go up and down or it stays kind of like the lines?
No, acidity changes, of course, because parietal cell secretion is stimulated by food intake. So in between the meals, acidity is much lower. But then also when acidity becomes too high, when pH becomes very low, like below 2, the acid secretion is inhibited by feedback by somatostatin mechanism.
So this is the range of the stomach space?
Yeah, this is the range, human range, yes. So stomach is not the major site of digestion of anything, including proteins. Proteolytic enzymes in the stomach do not normally break proteins towards the absorbable forms, towards the amino acids. They break to polypeptides. And it starts with initial proteins denaturation and then breakdown to the polypeptides. So the major digestion towards the absorbable forms, which are amino acids and very short polypeptides, like 2-3 amino acids, this is happening in the duodenum. Hydrochloric acid also controls the motor and secretory function of gastrointestinal tract. It controls the opening and closure of pyloric sphincter. So if pH of the chyme that is released into the duodenum from stomach is very low, pyloric sphincter closes. Hydrochloric acid has antibacterial action. It prevents the growth of bacteria. It prevents colonization of mucous membrane by bacteria. And we will see later how H. pylori overcomes this. Hydrochloric acid is important for the iron absorption because it reduces ferric form into the absorbable form, which is ferrous form. So parietal cells which secrete both hydrochloric acid and intrinsic factor are very important for the normal RBC production. And in case there is a significant atrophy of the stomach mucosa and stomach glands or resection of the stomach, which decreases the number of parietal cells, anemia develops. So anemia develops for two reasons. First of all, there is not enough ferrum, and secondly, B12 is not absorbed. B12 is not absorbed in the stomach. B12 is absorbed in the ileum. But for B12 to be absorbed, and it's important part of heme secretion, intrinsic factor is required. And intrinsic factor is secreted by parietal cells. Yes, please.
So, if we have both iron deficiency and vitamin B12 deficiency, do we have both macro and microcytic anemia?
It's it may be one of them, but
No, only microcytic.
But we have vitamin B12.
microcytic, but
Macro, it wouldn't go to the micro. Like the cells when they don't divide, same big.
So we have iron deficiency also.
But they wouldn't get.
if there is an iron deficiency, it's micro. So it would be by default. I mean, there was. So that is why patients after gastric resection may require a lifelong supplementation of B12. Yes, please.
Would patients with acid reflux have higher rates, higher concentration of ferrous?
I don't think so. I'm not sure. I don't think so. So pepsin is secreted in inactive form and is activated by acidity of the gastric juice. To prevent inactivation of pepsins, the pH should not drop below 3.5. Gastric mucosa can be damaged by high acidity of the gastric juice, that is high level of hydrochloric acid, and also damaging effect of pepsinogens, that's autodigestion. So that is why there is a number of factors that serve as protection for the gastric mucosa. And first of all, it's mucus and bicarbonate secreted by the neck cells in the glands of the stomach. There is a lot of mucus secretion in the antrum and pyloric part because, as you remember, they are horizontal portion of the stomach where acid potentially can be accumulated and stay for some time as the chyme is released in portions into the duodenum. So that is why this part of the stomach is protected. Same as cardia, in case of reflux, there is increased gastroesophageal reflux. There is increased secretion of mucus to prevent, to protect both cardia and esophagus. Prostaglandins also serve as protection. They inhibit secretion of hydrochloric acid by parietal cells. Mucosal blood flow is very important. So in case of ischemia, prolonged ischemia of the stomach, in case of the block of the vessels in the stomach. The mucosa can be affected, and potentially this can cause ulcers. So such are the ulcers that develop, for example, in patients after significant burns. When there are burns, there is significant loss of plasma through the burnt surface, and this leads to ECF constriction, which potentially decreases blood supply, including blood supply to the stomach, and can lead to ulcers. Also, there are stress ulcers, which again are associated with decreased blood supply to the stomach. Growth factors enable the continuous once in 3 days change in the epithelial lining of the stomach, and tight junctions in between the gastric epithelial cells provide the leakage of gastric juice under the epithelial lining, which is also damaging, of course. Damaging factors apart from hydrochloric acid and pepsin are H. pylori, and often patients with gastritis are tested for the presence of H. pylori and treated. So antibiotic therapy is a part of complex treatment, usually for gastritis and ulcers. And long-lasting intake of non-steroid anti-inflammatory drugs. Stress, smoking, alcohol, because smoking also causes significant vasoconstriction and decreases blood supply to the mucous membrane, which is potentially damaging. H. pylori is causing gastritis because it increases hydrochloric acid secretion. So how does H. pylori overcome the damaging action, antibacterial or bactericidal action of hydrochloric acid? Yes, please.
Urease enzyme. It uses the urease enzyme. So I think urease is related to ammonia. So it might create a pocket of ammonia or high pH capsule.
Yes, very good. Yes, please.
Urease turns urea into ammonia,
Yes.
which is basic. So neutralizes
Mhm.
acid.
Right. So urease converts urease is an enzyme that converts the urea into ammonia. Plus ammonia also, it's protective for the H. pylori, which develops in the gastric mucosa, colonizes the gastric mucosa of the stomach. Plus, it's also ammonium that is produced, and ammonium is by itself damaging to the gastric mucosa, being an acid. So H. pylori also suppresses D cells and releases the G cells from the inhibitory influence of somatostatin, thus additionally increasing hydrochloric acid production. When it comes to duodenal infection by H. pylori, duodenum is protected because initially the medium in the duodenum is alkaline. So duodenal ulcers develop when there is excessive hydrogen production in the stomach and excessive damage to the duodenum. But in duodenum also H. pylori decreases the secretion of bicarbonate. Peptic ulcer disease. There is a difference in the mechanism of development of duodenal and gastric ulcers. So gastric ulcers normally develop as the lack of protection for the gastric mucosa, that is ischemia, that is infarction of the stomach, that decreases the blood flow, that is the influence of non-steroid anti-inflammatory drugs. So everything, smoking, alcohol, so everything that potentially can damage the mucosa. While the ulcers in the duodenum develop as a result of excess hydrogen secretion, like for example in Zollinger-Ellison syndrome, which we will consider, we'll look at later. So increased secretion of hydrogen ions and damaging influence of acid on the mucous membrane of the duodenum is the major cause of peptic ulcers in the duodenum. So why does long-lasting intake of NSAIDs cause peptic ulcer?
Decreases prostaglandins, which you need prostaglandins in the mucus and the parietal cells.
Yes,
Inhibits
correct.
COX-2.
Not seriously.
Mucus, yeah. So that's why patients who have to take NSAIDs for a long time, like for example for arthritis, they are recommended to take other than pills form. So they are recommended to switch to ointments, to patches. Also through skin, NSAIDs would get into the blood anyway, so it would still be damaging influence of NSAIDs, but it would be not that fast, not that aggressive. So, yes, please.
How do NSAIDs damage the mucosa?
They do.
But how? Is it ion?
Oh, how do?
It's by far.
They increase the acidity of the stomach.
What?
They increase the acidity of the stomach.
They act via prostaglandins because they NSAIDs cause anti-inflammatory action by inhibiting prostaglandin production. And prostaglandins are protective for the gastric mucosa. So NSAIDs, it's their mechanism of action. They inhibit prostaglandins because prostaglandins are pro-inflammatory kind of neurotransmitters, but at the same time they're protective for gastric mucosa because they suppress secretion of hydrochloric acid. So why are patients treated with antibiotics for gastritis? Yes, because in most cases the reason is H. pylori. H. pylori even causes one form of gastric cancer, which is treated by antibiotics only. So we will be talking about the motor function of the stomach. And stomach has two sphincters which completely seal the stomach cavity from esophagus and from the duodenum. It's lower esophageal sphincter and pyloric sphincter. So like all the sphincters in the body, they are tonically constricted, so they are kept closed. And they are opened whenever inhibitory neurotransmitters are released from the parasympathetic nerves. So inhibitory neurotransmitters are VIP and nitric oxide. Lower esophageal sphincter, as you remember, opens with swallowing and then quickly closes. The pyloric sphincter is under the control of gastrin. So gastrin is known for its ability to promote gastric emptying. So it causes contractions of the pyloric part of the stomach and opening of sphincter. But we need to say that pyloric sphincter is its activity, its state, opened or closed, depends mainly on the content of the chyme. So if the chyme released into the stomach is too acidic, hyperosmotic, has high level of fatty acids and peptides, it means that it was not sufficiently processed in the stomach and pyloric sphincter closes. The cells that are forming the gastrointestinal tract, the muscle cells forming gastrointestinal tract are all smooth muscle cells. Stomach has additional oblique layer, which is innermost layer. And smooth muscle cells, as you remember from foundations, they have automaticity, so they have pacemaker activity. And as you remember, the smooth muscle cells are pretty much never at the complete state of rest. So from the state of rest, because they have this funny sodium channels, the channels open and their membrane potential is never completely at rest. So pacemaker activity to the muscles is provided in the gastrointestinal tract by special cells known as cells of Kagel. So these cells are a combination between fibroblasts and myocytes, and they are present as the thin layer in our Bach's plexus, forming connections with both longitudinal and circular muscle layers. And so they generate these so-called slow waves with different frequency in different parts of the gastrointestinal tract. It's about 3 to 5 per minute in the stomach, and it's more in the small intestine, up to 20, 8 through 20, 12 to 20, and 6 to 8 approximately in the large intestines. When potential opens smooth muscle cells, it's not just the sodium influx during the fast depolarization phase, but it's also calcium influx through the L-type calcium channels. So smooth muscles depend on extracellular calcium, mainly for their contractions because they don't have enough of endoplasmic reticulum with calcium like skeletal muscles do. So calcium enters smooth muscle cells during their depolarization phase. So this shows the membrane potential at rest. It's not really action potentials, but they are fluctuations in membrane potentials which are not reaching the threshold and not causing the excitation. So on top of this basic potential and fluctuations of potentials under the influence of pacemakers, there are of course nervous and hormonal influences on the muscles. And when these nervous and hormonal influences on the smooth muscle allow to increase the depolarization phase, slow depolarization phase to the threshold, action potentials develop. So this is when muscle can contract, when action potentials develop. The high is the frequency of action potentials, the high is the force of contractions. We remember that action potentials cannot change their magnitude, but the force of contractions is controlled by the frequency of action potentials. So the higher is the frequency, the greater the force of contractions. So this graph shows that high frequency increases the contractile response, increases the magnitude of contractile response due to tetanization. Yes, please.
Does amplitude have an effect, or it's only frequency?
Amplitude of what?
Of the action potential.
Amplitude of action potential cannot change. It's a stable parameter.
All or nothing response, right?
All or none, exactly. All or none law. Wherever this action potential develops, smooth muscles, neurons, doesn't matter. So the major function of the stomach is to serve as the reservoir for the food. So it consumes the food and provides initial mechanical due to mixing and grinding peristalsis, and initial chemical processing due to hydrochloric acid. But again, the major site of digestion of the food is duodenum, not stomach. Okay. So that is why adaptive relaxation of stomach when the food enters the stomach is important. We already talked about receptive relaxation of the stomach, which follows swallowing and opening of lower esophageal sphincter. Stomach relaxes, that's receptive relaxation. But then as the food keeps coming into the stomach and stretches the stomach, it's adaptive relaxation to adapt for the food. So due to this mechanism of adaptive relaxation, stomach can be stretched because it does not constrict, it does not have limit of food entering the stomach. And most patients who are morbidly obese due to overeating, they have the volumes of stomach come to 15 and 20 liters. So there is kind of no limit, unfortunately, to the stomach size. So when the food gets into the stomach and gastric receptors stretch, vagal afferents take it to the medulla where the motor nucleus of vagus is located, and efferents take it back to the enteric nervous system in the stomach, causing a release of inhibitory neurotransmitters and relaxation of the gastric muscles. So apart from relaxation, which increases the volume of the, yes please.
So when does the adaptive relaxation happen again?
When the food starts getting into the stomach.
But doesn't the stomach start contraction to mix and grind?
It does, but adaptive relaxation means that stomach technically has no limit of food consumption. It can stretch to accommodate any volume pretty much.
So what relaxes? The muscles relax?
Muscles relax. But then, of course, there is peristalsis. Mixing and grinding is basically here. Antral pumps. When evacuation, this is tonic contraction, also in the body. So body does two functions. Stomach relaxes to accommodate the food that is coming into it, but also once the food stops coming, we finish eating, and lower esophageal sphincter stays open all the time. Then mixing peristalsis is initiated. Contractions in the body of the stomach are initiated to mix the content. So antral pump is important for mixing and grinding because it also provides kind of backward peristalsis, which is intensive mixing and grinding of the food in the antrum. And again, pyloric sphincter opens by the initial mechanic pressure on it, and the first portion of chyme is evacuated. So initially, the first opening of pyloric sphincter is due to the accumulation of food in the antrum and pylorus, and pressure, just mechanical pressure on the pyloric sphincter. But then, once the first portion of chyme is evacuated, the duodenum analyzes, the receptors in the duodenum analyzes chemical content, and based on the chemical content, pyloric sphincter would either keep opening in portions or would close to provide further digestion of food in the stomach, further processing of food in the stomach, and then opens. All right. Compared to small and large intestines, stomach has the fastest evacuation rate. So the solids, which is dashed line, stay in the stomach for maximum 6 hours, while if we look at the time during which solids stay in the duodenum, for example, it's 7 hours. In the intestines, up to 10 hours. Liquids are evacuated from all parts of gastrointestinal tract at a faster rate than solids. It's much faster in the stomach, and then it slows down because most part of the stomach is vertical. So the content of the stomach is largely under the influence of the force of gravity, which allows quick evacuation of liquids. It's again emptying time. Liquid meal evacuates, 50% of it evacuates in the first 20 minutes. After 1 hour, that's pretty much all of it, 95%, 90% is evacuated. Not the same for semi-solid meal, which stays, 60% of which stays after 1 hour, and for the solid meal, 40% stays after 1 hour. So evacuation of food from the stomach or gastric emptying is under the control of nervous and hormonal mechanisms. In the intestinal phase. Overall, gastrin causes contraction of the antrum and pylorus and relaxation of pyloric sphincter to promote evacuation of gastric content. So gastrin stimulates evacuation of food from the stomach. But at the same time, in the intestinal phase, there is inhibition. There may be inhibition of evacuation through the short and long reflexes provided by enteric nervous system short reflexes and sympathetic nervous system long reflexes. So sympathetic is inhibitory for the secretions and contractions. But again, as I said, the first portion is evacuated just due to distension by the volume and opening of pyloric sphincter. Later, pyloric sphincter is controlled from the duodenum by enterogastric reflexes based on the chemical content of the chyme, that is pH, osmolarity, content of fatty acids, amino acids, and saccharides. Vomiting reflex. Vomiting reflex is largely a protective reflex performed by the brainstem, by medulla. So there is a vomiting center in medulla, which receives sympathetic influences from the stomach, coming from the distension of the stomach, from mechanoreceptors, from the distension of the stomach. So if a patient consumes the food that cannot be, maybe too much, or cannot be properly digested, there is a huge distension of the stomach, which by the afference of sympathetic nervous fibers gets into the medulla and stimulates vomiting to protect the body from stomach over distension and from GIT malfunction that may follow. So the vomiting reflex is executed with the involvement of cranial nerves, which nuclei are in the medulla, that is 9th, 10th, 11th, 12th, and also in the pons, that is 7th and 5th partially. Some of them are sensory, others are motor. So the efferent fibers are somatic nerves that go to they're not shown here. Somatic nerves that go to the diaphragm, phrenic nerve, and also to the anterior abdominal wall. So a contraction of diaphragm flattens down the dome of the diaphragm, which would then be pressing on the stomach, and contraction of the muscles of the anterior abdominal wall would additionally press on the stomach, causing evacuation of gastric content by opening of the lower esophageal sphincter. But to make this coordinated and to protect once this backward peristalsis is happening, to protect the nasopharynx, to protect the larynx and trachea from the acidic content of the stomach, there is also coordinated contractions of the soft palate to seal the nasopharynx. The glottis is closing the esophagus, the epiglottis, pulls backwards to close the entry into the larynx. Right, so this is all happening simultaneously, because the vomiting center as well as the nuclei of these nerves forming the vomiting centers are in medulla. Apart from mechanoreceptors which respond to the stretching of the gastric wall, the vomiting can be triggered also by the chemical drugs, for example by morphine, by digitalis, which is one of the most toxic substances. That is one of the favorite poisons of Agatha Christie, if you like reading her detectives. So this chemoreceptor trigger zone, which is present at the fourth ventricle of the brain, which is on the border between medulla and pons. So this is the fourth ventricle. Here we have chemoreceptor trigger zone. So this can trigger vomiting due to the factors coming from the blood, not necessarily from the stomach, even on empty stomach. Yes, please.
Hormones that are present, they're elevated in pregnancy. Could they also cause vomiting reflex via the fourth ventricle, like morphine?
I don't think so. But remember that in pregnancy, dependent on the stage of it, the stomach is already
that's what they're sensitive to.
not distended, it's pressed.
But the fetus.
Yeah, because the stomach is not distended by the fetus. Fetus is not in the stomach, right? But stomach is pressed already and it's under pressure.
So that's why they're sensitive to vomiting.
Mm. Can I answer any questions?
Is vomiting reflex related to gag reflex?
Well, gag reflex can be initiated by vomiting, yes.
Like, for example, for example, if I put my finger in
Yes,
my
this is-
pharynx, why does it cause outward peristalsis and not inward peristalsis? Like, shouldn't it cause me to swallow instead of, like, gagging?
Mm. So this is glossopharyngeal nerve contraction. That is what it does. Yeah. Not sure. I may come back to it because in the natural swallowing, you are not you are not like distending the pharynx and nasopharynx. In the natural swallowing, nasopharynx is already sealed. And by doing the gag reflex, you are doing it against the open nasopharynx.
Oh,
And
because there's
the
a
whole
swallowing
system
part.
is, yes, it's not the natural events in the swallowing. All right. Can I answer any questions? Yes, please.
Does gastrin cause contraction of the lower esophageal sphincter?
No,
It doesn't.
no. Pyloric. I mean, pyloric relaxation and contraction of pylorus and antrum.
Yes.
Because the overall effect is gastric emptying. Thank you.